patients with vomiting, the chloride will be low and there will be metabolic alkalosis. While in diarrhea, patients will have hypokalemia, hyperchloremia and metabolic acidosis. Now, how do we treat it? Answer is that almost 90% of the patients will be comfortable and all problem will be treated when we use oral rehydration solutions. Just word of caution that when we instruct our patient to use ORS, we need to instruct them that take 1 liter of bottle, add total content of the packet of ORS in the same, mix it properly and then use it. Because many times our patients make mistake that they just take a spoon of ORS, put it in the glass, add water and take it, which is inappropriate. Its composition will not be ideal and therefore its benefit will not be adequate. So this is something which is important while instructing the patient. Now, when small group of patients where oral ORS is not adequate or not possible, or patient is in hypotension and we need to correct hypovolemia immediately, properly, then which IV fluid is preferred? Answer is that ringus lactate. Now, why ringus lactate? Because it provides water. Sodium content is 130 milliequivalent, so provides sodium. It has lactate which gets converted into bicarbonate and therefore corrects metabolic acidosis. It has, although small amount, but has potassium, so it also helps to correct the potassium deficit, and therefore this is the most preferred and widely used first line therapy to treat diarrheal deficit. So when you think of diarrhea, think of ringus lactate. Small group of patients with severe hypokalemia may need even additional potassium supplementation. Some of the patients with severe acidosis may require even additional bicarbonate therapy. So this is something which is basic. So to summarize, when you see the patient of vomiting, don't wait for any investigation to come. Start with the isotonic saline. It's the most physiological way. And in the same way, when it is the therapy of the diarrheal deficit, first preferred IV fluid is the ringus lactate. So with this, we will go towards, because I am an nephrologist, 2-3 slides about fluid selection in kidney failure I will discuss. And discussion is what? That don't give IV fluid unless it's mandatory. Avoid administration of IV fluid because there is a possible risk of the volume overload and its complications. Hypertension is common, so restrict sodium to control hypertension and NSAIDs. Hyperkalemia is possible risk in renal failure, so restrict and avoid any of the fluid which contains potassium. And very important that like any other patient, even renal patient needs caloric replacement. So this is something which is basic. Now, when we talk about the fluid selection in renal failure, avoid all isolates because they are rich in potassium. Ringus lactate, in those patients where there is severe acidosis, the conversion of lactate to bicarbonate may be problematic, and therefore it may not be preferred when there is severe acidosis. And RAL, normal saline, DNase, because they are rich in sodium. Normal saline and DNase has a 154 milliequivalent, or we can say 9 gram of salts per liter. Ringus lactate has 130 or 7 gram of salts per liter, and this sodium-rich fluid may aggravate NSAIDs and may aggravate hypertension, and therefore should be used judiciously in calculated optimum volume. So this is something which is important. Now coming to fluid selection in liver failure. See, some of the basic things is that these patients are prone to develop hypovolemia, hypokalemia, metabolic alkalosis, hyponatremia, and hypoglycemia. So these all parameters we need to keep in mind. So first and foremost, we would like to emphasize that hypokalemia needs to be taken care properly. Why there is risk of hypokalemia? Because of vomiting, and in cirrhotic patient we may be using diuretic. So this can lead to hypokalemia and metabolic alkalosis. The hypokalemia is important because the presence of the hypokalemia stimulates renal ammonia production, which can precipitate or aggravate hepatic encephalopathy, and therefore look at the potassium and try to correct it as much as possible, as fast as possible. And therefore oral route is preferred, but if not corrected, then we may have to give even potassium in IV fluid. Second thing, that when it comes to administering fluid in patients with hepatic problem, patient with liver failure, we are always focused on more of the hypoglycemia, providing adequate calories, and we feel that oh, sodium is not something which is required much more. But we need to keep in mind that vomiting can cause fluid and salt loss, and there is even some normal sodium requirement. So if patient is having hypovolemia, metabolic alkalosis, for its correction, it is important that sodium containing food should be given. When there is metabolic alkalosis, always we give saline and we give potassium to correct hypokalemia, and when both are given simultaneously, then only our patient with hyponatremia and hypokalemia will improve. So pay proper attention to sodium. It's important even in patients with hepatic failure. And then last thing, which all of you very well know, is that these patients are prone to develop hypoglycemia due to decreased glycogenolysis and gluconeogenesis, that is glucose storage in the liver. And therefore, round the clock, administration of the 10 or 20% dextrose is important considering the fluid status of the patient. Oral is also fine, but then we need to keep proper watch, and at least 100 gram of dextrose, at least 100 gram of dextrose is something which is mandatory. So to summarize, that in patients with liver failure, adequate dextrose administration round the clock and prevention of the hypoglycemia is important. We need to provide adequate sodium, so you can use dextrose saline round the clock in slow infusion, and provide adequate amount of potassium. So this is something which is important. Now, the first part we were dealing was with basics of IV fluid and its administration in clinical practice. So now the second part I would like to emphasize and discuss is recent concept of fluid resuscitation. But before going to this talk, I would like to thank all my friends for supporting this book, Practical Guidelines on Fluid Therapy, which has crossed more than 1 lakh of copies. And that's possible because everybody is supporting, everybody likes this simple book. Book is available in most of the counters, but because of the corona problem, currently its availability may be problematic, but it's easily available on Amazon. Now, when we talk about the fluid resuscitation, this is important. It's a hot topic. There is a changing trend. Now, overall, if you look at the concept which was prevailing is with the time keep on changing, and therefore we would like to see that how things are changing and what is the current concept. The resuscitation fluid is a fundamental component of the management of all acutely ill patients. As there is change in all different aspects, if you whatever may be the field, but things are changing. In the same way, the things are changing even in treatment of the fluid to be given in hypovolemic shock or fluid for resuscitation. Timely proper treatment is something which is evolving. So prompt and perfect selection of the fluid is something which is mandatory. Now, in this hot topic, we need to know that when there is a need, how fast to fluid to give, how much to give, and which fluid to give. This is important to be answered because right time, right dose, and right fluid save lives. Now first, that what is the right time? So when patient comes, we give IV fluid, that's the right time. No, that's not right time. When we give IV fluid, the initial volume of IV fluid to be given is something which is critical. So early adequate resuscitation has the great advantage, and therefore when patient comes to us, at that time, the right time and encashing initial hours by adequate fluid replacement is something which is evolving. So what is this initial hours which we are talking about? In surviving sepsis guidelines, they said that right time is to administer adequate volume in first 3 hours. So it's not that patient has come and you have given IV fluid is okay, but you have golden period of first 3 hours, and these 3 hours should be used very properly. So why this first 3 hours golden period is important? Because when there is delay in administering IV fluid, longer the delay, there will be more microcirculatory hypoperfusion. And when there is more microcirculatory hypoperfusion, there is a risk of organ damage. And because of the delay in administrating fluid, delay in increasing the blood pressure, there is increased risk of multi-organ failure. So, 3 hours, first 3 hours is the right time to provide adequate fluid. So the question arises that what is the adequate fluid? What is the right dose? In surviving sepsis guideline, they said that at least in general, you have to look at every patient individually. But broad general guideline is that 30 ml per kg of crystalloid fluid is something which is very important, which we need to give in first 3 hours. So if patient is weighing say 70 kg, then in first 3 hours, 2 liters of IV fluid in hypovolemic shock is what recommended by surviving sepsis guideline for initial resuscitation. Now, we need to look at all parameters and hemodynamic assessment should be done. But as per recommendation, the initial target is, instead of systolic blood pressure, the mean arterial pressure, that is 65, is considered to be better. Now, why mean arterial blood pressure is better? Because it is a better indication of perfusion of vital organ than systolic blood pressure. Now, it's simple. Calculating mean arterial pressure is very simple. That 2 times diastolic blood pressure plus systolic blood pressure multiplied by 3 is mean arterial pressure. So if blood pressure is 120 over 60, then 60 into 2 comes to 120, and 120 plus 120 is 240 multiplied by 3 is equal to 80. So mean arterial pressure will be 80. So when you calculate mean arterial pressure, that will provide you better guidelines. It will be a better reflector of the perfusion of the vital organs. Now, the last question which comes to us is what is right fluid? See, this is very important. like to have this discussion in four different aspects. First, physiological basis on which we plan fluid therapy. Second thing, that we have two groups of fluid, crystalloid versus colloid. So we will try to differentiate it. Then amongst crystalloid, we have saline and balanced solutions. So that we will discuss. Finally, we have balanced fluid where standard ringus lactate and newer plasma light. So is there any need and why? So under these all four headings we will discuss. We start with the physiological basis of selecting IV fluid. So out of this fluid, which fluid should be used? We have many fluids to us. When it comes to selecting IV fluid for resuscitation, the fluid which expands intravascular compartment in better way is the preferred IV fluid. Now suppose if we give 1 liter of dextrose 5%, then how much will be approximate, say if we have given 1 liter of 5% dextrose, how much is going to be the expansion of the intravascular volume, because that is going to determine rise in the blood pressure. So out of 1000 ml, will it be 500 ml? Will it be 400 ml? The answer is something which is surprising to most of us, that when dextrose 5% is infused, the dextrose is consumed and water is distributed in all compartments equally. And therefore, out of 1 liter, only 83 ml will be retained inside the intravascular compartment. So, when we instruct and when we talk with our duty doctor that fluid is given, sir, madam, 1 liter of fluid has given, but blood pressure has not improved. So, physician may think of septicemia, surgeon may think of internal bleed, but it may be improper selection of IV fluid. Because by chance, if 5% dextrose is given, then the expansion will be only 83 ml, and therefore patient will not have rise in the blood pressure. Against that, the fluid like isotonic saline and ringus lactate are preferred and more potent because they are sodium containing fluid. Sodium compartment, and therefore with smaller volume, rise in the blood pressure will be much greater. Not only that, some of the hypertonic fluid like 20% albumin will shift from other compartment to intravascular compartment, and the expansion will be even greater than the volume infused, and therefore colloid and blood products are preferred and most potent amongst resuscitation fluid. So colloid and blood are most potent, but isotonic saline and ringus are most preferred. And if you look at this slide, glucose hardly 10% is retained. Crystalloid, RL normal saline 25% retained. Colloid and blood 100% retained. And because of this ability, when we look at the distribution of any fluid in all three compartments, we avoid dextrose 5%. We prefer, because of its good capacity to raise the blood pressure, normal saline and ringus lactate, and we find colloid as most effective. So take home message is that while resuscitating fluid, keep your eyes open. Select fluid properly. RL and saline are preferred. colloid and blood are most potent, and never use 5% dextrose or isolite for initial treatment of hypovolemic shock. Sir, we have given 1 liter of fluid. Blood pressure has not increased, but the patient has become drowsy. Which fluid was given? It's 5% dextrose. So 5% dextrose will not increase the blood pressure, will aggravate hyponatremia, and therefore is harmful. Don't use isolites for 2 reasons. Number 1, they are poor in sodium, and therefore their ability to raise the blood pressure will be poor. And second thing, that it is rich in potassium, and when large amount of fluid needs to be given rapidly in initial 3 hours, let's say 30 ml per kg, like 2 liters, then such a large amount of potassium in hypovolemic polyuric patient can be harmful and therefore should not be used. Now, we feel that, oh, saline is good, but if we give dextrose saline, then patient will also have benefit to get some calorie replacement. So, can we use dextrose saline instead of normal saline for resuscitation? Answer is no. No. When there is rapid administration, like 2 liters in first 3 hours, the rapid dextrose administration will lead to hyperglycemia even in normal persons, and this will act as osmotic diuresis. So patient will have good urine output, and when we are assessing patient, we said, oh, fluid is given, yes. How is the urine output? Madam, sir, output is good. Okay, then slow down rate of infusion because blood pressure is, urine output is improving, so patient is doing well. So it's a misinformation, and that is something which makes our decision wrong. So on one side, patient is hypovolemic and fluid is lost. On another side, we reduce the rate of administration. And because of this reason, in patients with hypovolemia for resuscitation, don't use dextrose containing IV fluid. Any of the dextrose containing IV fluid. Avoid all dextrose containing fluid for rapid fluid replacement. RL and saline are preferred. So, with this basic physiological understanding, then we proceed further and discuss that in resuscitation, which fluid to use, crystalloid or colloid. See, already we have discussed that both are good, but there is a great debate, and we have 4 runners with us. In crystalloid, we have normal saline and balanced fluid. In colloid, we have albumin and hydroxyethyl starch. Now let us see. I request all of you to select one player out of all, that which will perform best at the end, and then let us see how things goes. Now, when it comes to physiological basis, crystalloid and colloid is no way comparable, because crystalloid is good, but colloid is better. The colloid has advantage of greater, faster and longer effectiveness in plasma volume expansion. And therefore, when we look at that parameter, crystalloid cannot match the colloid. But there are other factors, like in addition to efficacy, there are other factors like safety, adverse effect, and what is the outcome in studies. And if we look at the literature and review it, then only we can opine about it that which fluid will be used. So, crystalloid and colloid, we will have discussions: albumin versus crystalloid, hydroxyethyl starch versus crystalloid, and then in general colloid versus crystalloid. Now, albumin preferred by intensivists very much because it's good, but whether it cures or kills. If we look at the literature, 2 major studies, SAFE study 2004 and Albio studies 2014. These 2 major trials, what it says. In 2004, SAFE study says that in conclusion, use of 4% albumin or saline for fluid resuscitation has similar outcome at 28 days. So SAFE study no superiority of albumin. Likewise, albio study, where they use 20% albumin, no difference in mortality at 28 or 90 days. And therefore, what is the conclusion? That current guidelines cannot endorse the use of albumin in light of its expense and current lack of proven benefit. So, what is the status of albumin? Answer is that albumin should be considered as a second line agent. Remember, albumin is a second line agent for fluid resuscitation. It is indicated. Then when should we use it? It is indicated in patients unresponsive to crystalloids or when the amount of crystalloid required is very large, which patient cannot tolerate. So it's not crystalloid versus albumin, but it is crystalloid additionally albumin in selective patients. This is what is an important take-home message. Now, amongst all colloids, albumin is preferred. It is better, safer than hydroxyethyl starch and other agents. So, albumin cures because it is safest and most effective colloid. So, in selective patients, it has a great value. But it is 100 times more expensive and it has not shown to be demonstrated not to have a better outcome at 28 or 90 days, and therefore for that small duration achieving higher blood pressure, this is achieving higher blood pressure and restricting fluid, this is important, but otherwise does not make any difference. Hydroxyethyl starch, the story is so much controversial. If you look at various trials, 6S trial, chest trial, crystal trial, 2013 Cochrane review, and 2013 PRSA recommendations. Every trial says that it is harmful, causes AKI and mortality. So in 2013, the recommendation was no longer used in sepsis, burns, or critically ill patients. Should be used selectively in lowest effective dose and for shortest time. But if everywhere things are same, people keep on using this molecule widely without looking at the safety of the patient. And therefore, due to its unrestricted indication and irrational dose and use of hydroxyethyl starch, there was a lot of problem, and it was because of that there was unacceptable adverse effect. So in 2018, there were breaking news. In January 12, 2018, PRSC, that is European guidelines, say that this should be banned. Suspension of marketing of this solution from the market was recommended by European medical agencies. This banning was really big news and big problem in medical field. And it seems that it's the end of the story because it was banned by European agency, which is a big organization. But no, that's not the case. Killing cow to get rid of ticks is not the right answer. So, because it is used irrationally for non-indicated case, for larger dose, and because of that there is side effect, and therefore it should be banned, is not the right thing. And therefore, there are studies which says that in surgical patients, when it is used properly, it does not really lead to so much of the side effect. And therefore, in June 2018, again, European agency has modified their recommendations and they said that no longer used in sepsis, burns, or critically ill patients because of the risk of kidney injury and mortality. The only indication where it is recommended is to replace acute blood loss induced hypovolemia, and that is in surgical patient. And very, very essential to know, lowest effective dose, shortest period of time, dose less than 30 ml per kg, and maximum duration just less than 24 hours. So this is what is the recommendation, and therefore take home message is that use selectively in surgical patients, avoid in medical ICU with multiple etiology. Now, last conclusion, that this was regarding albumin and hydroxyethyl starch, but what overall largest and latest study says, all has unanimous guidelines and opinion. Surviving sepsis guidelines, they said that crystalloid is preferred over colloid. So is this Nature Review 2018. Cochrane Data Review 2018, 69 studies, 30,000 patients concluded that crystalloid is preferred over colloid. In many other recent literature, it is conveyed the same way. So finally, what comes? Answer is that crystalloid are the primary fluid of choice for resuscitation in non-septic and septic patients. No indication currently exists for routine use of crystalloid over colloid. So colloid is potent and used selectively, but otherwise crystalloid should be used. So what is the recent advances? What is the status of colloids in our clinical practice? Answer is that it has benefit because of physiological basis. So it shortens the time to achieve hemodynamic wall, but increases the expense without improvement in outcome. More effective in reaching resuscitation hemodynamic endpoints. Requirement of the volume of fluid required is less, and therefore it stay in the intravascular compartment for longer time. So its persistent effect is bit longer, and because of all these indications, crystalloid is preferred over colloid, but colloid is used selectively in some of the patients for limited benefits. So both are complementary to each other, but start with the crystalloid and add colloid only in selective patients. Use colloid in few hemodynamically unstable, septic, surgical patients who requires large volume fluid resuscitation. Take home message that crystalloid is in and colloid is out. So out of 4 players, now we have only 2 players with us. That is normal saline and balanced fluid. So the question arises that which fluid should be used? This is the battle between the best, because both are very good. Which one to use, normal saline or Ringer's lactate? There is a lot of controversy. So we will look at some of the basic things, that what is the composition difference. See, if we look at the normal saline, it is not normal. Although it is considered as a normal saline, it is not normal for 2 reasons. Number one, if you look at the chloride is 154 milliequivalent as compared to 100 milliequivalent in plasma. pH is also low, and there is no buffer, no bicarbonate, no lactate, no acetate, and therefore this is not a physiological normal. And in many of the literature, they say that it is abnormal. So compared to that, if you look at the balanced crystalloid, all parameters, sodium, chloride, pH, osmolality, all are matching, unlike that of the chloride, unlike that of the normal saline. And therefore, this balanced fluid is like Ringer's lactate, is something which is better and preferred. Now comes the evidence. Normal saline is harmful. Why? Because there is supraphysiological chloride. Instead of 100 chloride in plasma, it is 154. And because of that, there is 50% higher concentration that leads to hyperchloremia, and that is dangerous, can lead to AKI, metabolic acidosis, and other complications. Now, why AKI occurs? Because there is increased chloride, and this chloride affects, see, it acts through the increased chloride concentration through macula densa, sends the signal, and that leads to contraction, vasoconstriction of the efferent arterioles, and because of that, there is decrease in GFR, decreased urine output, and AKI. But this is physiological. What is the data? What is the evidences say? So we have two rounds of fighting between normal saline and that of the balanced fluid. So first we will give opportunity to normal saline to prove its worth. So what is, where is the evidence that normal saline is better? See, normal saline is better than balanced fluid. Do we have any evidence? Answer is that it's from last 1 century, more than 1 century. Normal saline is the #1 fluid used worldwide. Annually, more than 200 liters of fluid are used only in USA. And by default, from our beginning of the career, we have been using this fluid for treatment of the hypovolemic shock. And it has advantage of easy availability, low cost, compatibility with the blood, and therefore this is preferred. But these are not evidences. This is experience. There is difference between experience and evidences. So last line is that saline is better than balanced fluid. We have no evidence at all. Now, is there any evidence that balanced fluid is better? If we look at it, then the evidence list is so long that I cannot really discuss all the evidences given here. See, large number of evidences in all specialty, in surgical specialty, in ICUs, in critical patients, in anesthesia, what not. And if you look at the literature, there are, this is in one of the articles they say abnormal saline, with that they start. Then in one of the heading they said that 0.9% saline is neither normal or physiological, very abnormal saline. I mean, the literature is so much that we cannot even describe. But the final punch, the final conclusive remark appeared in literature in 2018. That is was a SMART trial and SALT-PD trial. This trial, which appeared in NEJM 2018, it compared saline versus balanced fluid. And this SMART trial was in critically ill patient, while SALT-PD trial was in non-critically ill patient. So what was the conclusion of this trial? In SMART trial, they recruited more than 15,000 patients. And the conclusion was that there was lower rate of death, renal replacement therapy, or persistent renal dysfunction with balanced fluid than with normal saline. So this was a very well conducted big trial done in USA. And that's a changing concept. They changed the concept. And it has a great impact overall in all medical literature. Not only in medical literature, but in media it has appeared that fluid switch has big impact for small cost. The saline used in IV bag could be killing you. This is the newspaper which gave such remarks about selecting fluid after this SMART trial was published. The fluid war returns, can be restored balance to the fluid. And in Health Day, there may be a better fluid than saline, study finds. So there were a lot of literature, lot of discussion, seminar, and I mean all different ways. This was a big news, and one very good discussion done by Dr. George Farkas, that is in Olympic 2018, they said that smart trial, get smart, stop using saline. See, they critically analyze everything, and then they said that we have 9 reasons to stop using normal saline for resuscitation. It has no physiological rationale. It aggravates acidosis. It is dangerous in hyperkalemia. Hyperchloremic acidosis is harmful. It may cause hemodynamic instability in large volume. Carries increased level of inflammation, acute kidney injury. We have documented SMART trial, which tells us that balanced fluid is better. So when we have better options, why to select fluid like normal saline? So current trend favors balanced fluid. When we talk about normal saline, the chloride-rich fluid, there is no clinical benefit, no physiological benefit, cost benefit not measured, there may be harm. So IV saline is harmful. When we say IV saline is harmful with so much of the evidence, should we ban it? Should normal saline become the past? Answer is that no. We have articles that normal saline not dead yet. Absence of evidence is not evidence of absence. RL is good for many of the conditions, but is it perfect for all? No. It has calcium, which is incompatible with blood. It is not good because it provides bicarbonate. So in metabolic alkalosis, it is not preferred. In patients who has underlying other diarrheal conditions, this is not good and not suitable for neurosurgical patient head injury because of its hypoosmolality, because it can increase brain edema and cerebral edema. So it is used selectively in vomiting, metabolic alkalosis, hypovolemic hyponatremia, diabetic ketoacidosis, brain injury, and with BP. Research is that IV normal saline, not too much, not too quickly, and with healthy kidney is something that is good. Less than 2 liter of volume administration usually does not cause PI, but more than 2 liters is harmful. So conclusion is that RL versus saline, the preferred solution is currently balanced fluid, and use normal saline briefly. Acidotic critical patients should receive alkalizing balanced crystalloid, but alkalotic hypochloremic patients will be benefited with normal saline. Now, when we talk about ringer's lactate, no, it is a wrong concept. Hypotension means balanced fluid. Hypotension means ringer's lactate. So change habit of selecting fluid. Stop old habit, isotonic 0.9% normal saline as a preferred first fluid. Change your habit to ringer's lactate as the first fluid to be administered for fluid resuscitation. So, take home message is that resuscitation means ringer's lactate. Always use RL first, RL first, RL first. This is the take home message of my today's talk. Normal saline is not first fluid of choice, but use it selectively. It's not at all outdated. It's very useful. It is useful in vomiting in patients with metabolic alkalosis, hypovolemic hyponatremia, diabetic ketoacidosis, brain injury, along with the blood transfusions. In these all conditions, this normal saline is preferred and is better than ringer's lactate, better than any of the balanced fluid. So this is something which is very, very important take-home message. See, remember that when the amount of normal saline administered is small, less than 2 liters, then the risk of acute kidney injury, which is a major concern while using normal saline, is going to be less. But When more than 2 liters are used, it can be harmful, can cause hyperchloremic acidosis, AKI, coagulopathy, hyperkalemia, and therefore it should not be used. Plasma light, very good fluid. But take home message is not that replace Ringer's lactate with plasma light. Majority of the patient will be comfortable and will respond to Ringer's lactate. But plasma light has special indications and its great benefit lies in few of the patients who are very critical, severely ill acidotic patients with hypotension, diabetic critical patients, in patients with severe jaundice, brain, major brain, liver, cardiac or transplant surgery. These are the small group of patients where the value of plasma light is really great. So use this fluid selectively in such kind of patients. Albumin, very good, but second line agent. Don't think that it is first line. It is complementary and additional to that of crystalloid and not as a first choice. Most expensive. Used in a hypoproteinemic, septic patient, unresponsive to IV crystalloid, and in those who cannot tolerate large amount of crystalloid. So that's the use of albumin. Hydroxyethyl starch, harmful in all medical patients. Don't use in medical ICU critical patients. It is meant for surgical patients and that too to replace the blood loss. It can cause acute kidney injury, can increase the mortality. So, in surgical patients, use in lowest dose less than 30 ml per kg per day and for shortest period less than 24 hours. Then you will able to take all great benefits of hydroxyethyl starch. With this, I will end, but I will not miss this opportunity to brief my all valuable listeners, my friends, to brief them about kidneyeducation.com website, which is a mission to prevent and care kidney disease.